Hello, everyone. Happy Tuesday. Welcome to another virtual morning report. I'm Youssef. I'm a hospitalist in Atlanta, one of the CP Solvers members. Happy to be discussing with David, all the way from Spain. David, you want to introduce yourself?
Hi, friends. Yeah, I'm so excited to go discuss with Youssef, and especially Marcela's case that are always amazing. So yeah, I think Noah's describing and Mirahil's doing teaching points, right?
Yeah. And Marcela, do you want to say a word? Just
Yeah, hi everyone. I'm Marcella. I'm a PGY2 here, WashU. Happy to be here to present a case. I hope you guys will like it. I'm looking forward for the discussion.
yeah. I'm excited and scared, so let's do it.
Okay, so the patient is a 33-year-old female, and the chief complaint is 1 week of low back pain, right leg pain, chills, and fatigue. So I would like to see if you guys have any thoughts about that.
Okay, so it was leg pain or low back pain?
It was both. She had low back pain, um, right leg pain going to the knee with some knee pain, and the chills and the fatigue.
Okay. So yeah, I guess the first thing you think of when approaching back pain, and especially low back pain, and that is the one that we kind of frame as the back pain, is if there is any alarm features. And in this case, you could think that a 33-year-old female is a low risk population, unless we are hearing something about her past medical history, such as any cancer history or any immunodepression that well, I don't expect, but we will see. Um, and the accompanying leg pain may lead you to think towards a kind of sciatical pain, and that could make you think that this is not so severe in presentation, but the chills and fatigue are, yeah, I think a clue to maybe to underlying inflammation. And yeah, I think uh, could be could be approached as an alarm feature similar to fever or to weight loss here. We want to know I guess the pain is for 1 week here, but I don't know if the chills and the fatigue are more subacute in the nature, or are just from the same duration. If thinking of inflammatory back pain, I think you can think of like in anatomical approach. You can think of from the more deep structures, the spinal canal would be very unusual if we don't get any other information, but myelitis could present like this. We tend to associate it more with dorsal, I think, pain, more upper in the back, but it could be also a possibility. Also, well, any inflammatory process in the spine are also epidural abscess could be there. Also osteomyelitis, and yeah, and any other process, inflammatory process such as neoplastics and neoplasms in the spine. But yeah, I think the key question here is this patient needing urgent imaging or not. And the inflammatory nature could point to that, but we'll see if there's any other features and specifically any other neurologic involvement that could drive more a more urgent care here. What do you think, Yusuf?
Yeah, David, excellent intro. I think I agree with you. It's usually most back pain is just musculoskeletal, but here we hear about chills, which would be worrisome about could there be like an underlying bacteremia, right? So, like you mentioned, you want to make sure there's no like abscess in the back, and abscess and the mimics to abscess are like myelitis or like something radiating to the back. So, are we sure this is in the back? And because when we hear back pain plus leg pain, there are many options. They could be like just back pains radiating to the leg, or it could be, for example, something seeding both. There could there be bacteremia causing both, like a septic arthritis, for example, and like something inflammatory in the back. And the other option is could other than bacteria, we could think of something affecting the nerves, like viruses. Sometimes can cause neuropathies that can present acutely like this. So what am I thinking of right now? So what do I want? I think the big things that would change my management are one, if there's compression. So how would I assess that? So reflexes, rectal tone, bladder symptoms. These are the things I want immediately. I will check for an HIV test early and screen for other causes of immune suppression. And thirdly, ask for IV drug use, because if you hear about someone who has IV drug use, you will immediately, this is like a slam dunk bacteremia, right? So I think these are the questions that I want next as we head towards the exam and just gather things related to immune suppression. And that will help me stratify the patient further. And then when I'm going to see this patient, I'm gonna like look for like track marks. I will look for lower extremity weakness, reflexes, bladder symptoms. So that's where I'm at.
Well, amazing start. She told me that she had a lot of malaise, fatigue, and this mid low back pain with the right lower back pain and right knee pain. For 1 week prior to the presentation, she was very concerned about being exposed to a flu or COVID because she worked in a place that had patients with COVID. So she felt that she was having some flu-like symptoms in the past few days, having this diffuse body ache, some cough, sinus congestion, dyspnea. And then she mentioned a possible syncopal episode the day before presentation. That was one of the things that prompted her to go to the hospital. She said that she woke up on the floor. She was not sure if she really lost conscious. It was a very weird history, but maybe she had a syncope. Um, and she mentioned that she was having urinary urgency, but she thought that it was probably because of her pain. Her pain was so bad that she could not get up and go to the restroom. She denied having any dysuria or increased urinary frequency. She was just having that urgency and not being able to get to the restroom on time. She did not have any chest pain, any nausea or vomiting or abdominal pain. For the first few days when she was feeling sick, she took Tamiflu without improvement and was trying to use Flonase, which did not help. And then she also mentioned that she was concerned that she could be pregnant because her menstrual cycle was a month late. Any thoughts?
Awesome. Thank you, Marcella. And just a quick question. Is this patient in Brazil or are they in the US?
They are in the US.
Okay. Just to see what organism profile should I think of. But it sounds like here we have a prodrome of viral symptoms, of flu-like symptoms, body aches, cough, and a lot of times we see these with viral infections, and a lot of viral infections start in the upper respiratory tract. And how can a viral syndrome like progress? So you could have a viral syndrome that causes like an pneumonia, a viral pneumonia, but then that can be complicated by a bacterial infection. And we're wondering here, like if you just saw this patient and they just had the viral symptoms, no syncope, maybe you would say, oh, okay, maybe just wait a week and then let us know how you're feeling. And then if you're still feeling anything, we'll test you for viral illnesses, because most of the treatment is supportive. But then there's the question mark syncopal episode. And with this episode, the question is does it have any localizing value, or is this just the marker of severity of disease? Because when you have a syncopal episode, it means if it is a syncopal episode, you had a hypoperfusion to the brain. And that's how I think about syncope. Is like there was an event that triggered you to have a syncopal episode. And even though we learn about syncope as the big buckets are orthostatic, reflex, and cardiogenic, any cause of shock can cause syncope, for example. And we do use the shock framework, where S is septic / hypovolemic, O is obstructive, C is cardiogenic, and V is like distributive. And any one of these causes can start off, can cause a syncopal episode. For example, almost 1% of patients with syncope have a pulmonary embolism, for example. So in this case, I'm not putting value in the syncope. I'm not saying this is necessarily, I'm not triggered more towards the heart. I'm more thinking, could this be a marker of severity? And so I'm keeping that in the back of my mind as I initiate the workup. I'm not necessarily going to say, oh, this is a syncope, let me do orthostatics and echo. I think it's more like, could there be like a severe disease? David, I'm going to leave the rest of the history to you.
Yeah, I love that. I agree a lot with that thinking of the syncopal episode. We obviously we would love to deep have a little more information. Maybe if any relative can provide. But I would say the same as now. I wouldn't. I think this is not the chief concern of the patient, and would frame it initially as a marker of severity than anything else. The urinary urgency and the incontinence. Yeah, in the absence of other dysuria or other symptoms, likely not from a infectious or irritation process, but and a thought that came to my mind when Marcela mentioned this was the possibility of UTI causing a psoas abscess. That is a complication that could arise from UTIs, and that could cause low back pain. But I tend to think that this is more a separated process, and maybe glued to spinal involvement. Maybe cauda equina is not the typical symptom that we have, and there is more retention, urinary retention, or fecal retention, or also fecal incontinence. Incontinence could also be a symptom of cauda equina. I think both, like the two manifestations of this could be, could arise in this syndrome. Would love to know your thoughts in that. And the fact that well, this didn't improve with Tamiflu doesn't make too much for me, because if this was a viral syndrome, this would maybe wouldn't improve also with Tamiflu, and this doesn't move me into one way or other. The fact that this began with flu-like symptoms made me think of two possibilities. This being an kind of infection there is having any complication in the either the spine or the lumbar area, or also there are post-infectious syndromes such as for example ADM or post-infectious transverse myelitis that could also be now presenting with low back pain and the neurologic symptoms. I don't have a lot of thinking about the delay in the menses. I just would want to know that the pregnancy test is negative, because that will change all completely the management. But yeah, it's just a month. I don't know. I wouldn't put too much attention into that unless the pregnancy test is positive. What do you think, Yusuf, before giving more information about the urinary urgency?
Yeah, I think I agree with you. It's like maybe some urgency, and we're like, but no dysuria. Could there be like a neuropathic issue? And I'm still like trying to see if this is an actual problem, or so I will wait for the exam, I think, as well, to take it from there. And then similar to you, I wouldn't put any money just yet on the menses. And if the pregnancy test is positive, or we get a serum beta HCG, then I think that we can talk about it then. But I don't think I would to invest too much until we have like evidence of it.
Great. So for her past medical history, she has a history of having asthma. She has a history of having bipolar disorder. She also has a history of HIV. And according to the chart, she didn't follow up on the past few appointments. But she reported being compliant with the medications. Had a history of having hypertension, but was not taking any medications at the time. And she was taking Biktarvy and just a Buterol inhaler. For social history, she used to work in a place that, like I mentioned, had exposure to patients, denied any alcohol, any smoking history of drug abuse. She used to live with her children and was very independent on all her activities. For her physical exam, so her temp was 98.6, heart rate of 117, respiratory rate of 18, blood pressure 104/61, studying well in room air, her BMI was 60. On the general exam, her lungs were clear, didn't have any wheezing or crack holes. Her cardiovascular exam was also normal. Her abdominal exam, she had some diffuse tenderness, but nothing very remarkable, no guarding. And she had some 1+ low extremity edema, but was not very significant. And then in the neurological exam, we didn't see any objective weakness. Reflexes were okay. And rectal tone was okay. She was not having any problems with having bowel movements. And some of the exam was limited by pain, but overall we were reassured by her neurological exam. And I'll stop here.
Okay, Marcela, one question. Was she adherent to Biktarvy? I didn't get that.
She told us that she was. We had some
Okay.
initial concerns because she didn't follow up in the clinic, but she told us that she was taking, maybe missing a few doses, but not more than once a week.
Okay. So, well, that would change everything. So, I think it's very key history. The history of HIV here is very key, not just because of the possibility of non-adherence here to Biktarvy and being a picture of severe immunodepression that would make a clear scenario for imaging here, but also because the knowing the history of HIV, how did she get the HIV? Was she did she had any intravenous drug use? Did she had any other history of sexual infections that or any sexual risk behaviors that could also be a risk factor for other infections is key here also. And I think this would have been in real practice a very challenged case, because I imagine being with this patient in the ER. I think this is a high risk situation for underscoring what the patient is telling us because of the history and the obesity of the patient, that patients with obesity can have they of course they can have back pain due to musculoskeletal non-specific causes more than other population, but in this patient and also with the history of bipolar disorder, I think she's at risk of being dismissed by many physicians that could not address the symptoms as could be needed here. So just wanted to make that comment. I think that the exam that doesn't give us many clues to what is happening here. I don't make a lot of the bilateral leg edema, and the only thing that is remarkable for me is the tachycardia. Would love to make an ECG first, but I think with the history of chills and fatigue, would want to know if this is a sign of an underlying inflammatory process. But yeah, I don't have too much to add. What do you think, Youssef?
Yeah, to add to that, David, I think patients who are immune compromised, not only are they prone to regular infections, so anyone without HIV can get staph bacteremia, right? So they're also more at risk for the same infection, but they become more severe. So they're prone to the same infections and can get more severe, but they're also more prone to other infections. But depending on which arm of the immune system is down, you're prone to different infections. So if you notice with HIV, their T cells are down, and T cells are mostly affect intracellular organisms and fungi. So that's why if you notice, for example, with HIV, we worry more about CMV, for example, which is intracellular, or tuberculosis or crypto, which are like fungal or mycobacterial. And we worry less, for example, about a rhizopus or like a mucormycosis, if you notice. And the reason for that is that those infections are from a different arm of the immune system. So the initial thing I'm worried about is just bread and butter infections, regular bacteremias. And the things that also are different with patients who are immune compromised is that their exam is not as congruent with their syndrome. So for example, if somebody has HIV, is not immune compromised and they have bowel perforation, the chance that they have diffuse tenderness and guarding is very high. But if you're immune compromised, you might have more disease, but less findings on exam. So your physical exam becomes less sensitive. And that's something to keep an eye out for, because you're more likely to get imaging in someone who's immune compromised for this exact reason. And my exam for patients with HIV is always the same for almost everyone. And I start from head to toe. Like you start at the face and you look for seborrheic dermatitis. And then after that, I look in the mouth for a thrush, and I ask them if they're having pain with swallowing, because then you would need an EGD. And then I check for lymph nodes in the neck and the back of the head. And then I have them raise their hands. I check for lymph nodes under their arms and the groin. And then I take a detailed sexual history, and I would ask them what specifically do they do and how sexually active are they? Because you would basically need swabs of every organ they use for like sexual activity. And then I take it from there. So, and here it sounds like we have maybe some tenderness on exam, diffuse tenderness, and we're headed towards like imaging more or less. And I'm not gonna give like a differential before then. I think, like you, David, I'm still in the problem defining space, but it sounds like we're worried about a infection, an OS, and then after that we'll take it from there. Hope not much like neuro findings, maybe edema, maybe urinary symptoms, maybe something in the pelvic tract, but I think. I'm still in the problem generation phase. So if I was seeing this patient in the ED, I would still say abdominal pain in inflammatory abdominal pain in immune compromised patient, getting CT, abdomen, pelvis, and obviously like basic labs, and then we'll take it from there. And then other labs that I would want like upfront are like almost everyone will get a CD4 count and a lymphocyte count to see how immune compromised they are. The CD4 count is usually decreased in the acute setting, but the CD4 percentage is preserved. And then depending on the CD4 count, you will initiate other workup, and then we are most definitely going to get blood cultures.
Okay, amazing. So first thing, her pregnancy test was negative. So her white count was 23.4. It's mainly neutrophils. Her hemoglobin was 9.7 with an MCV of 80.2. Platelets of 78 from a normal baseline. And her hemoglobin at baseline was already low, around 11. Potassium was 3.9, sodium 136, bicarb of 24, BUN of 62 with a creatinine of 2.1, and her baseline was 0.9. Alk phos was also elevated at 202, with a total bilirubin of 3.1, AST of 24, ALT of 14. A normal phos, normal mag. The initial lactate was normal, lipase of 30. Her AKG was sinus tachy. They also did a UA in the emergency department. They show 1+ protein, 1+ bilirubin, 3+ blood. More than 50 white blood cells, but he also had 10 epithelial cells. So they suggest recollect the sample, and they didn't reflex to cultures. And then checking her CD4 was 564 with 36%, and her viral load was undetectable. And so here we were talking about imaging, but I want to check with you guys what imaging you would want and what you would do like next.
Awesome. Thank you, Marcella. So sounds like we have a significant neutrophilia, and with CP solvers, we do have like a broad schema for neutrophilia. Is that if the white blood cell count is like mildly elevated, then the differential is still like very broad, but the higher it goes, the more the differential becomes more specific, and the differential becomes specific and narrow. And the few things that cause like a markedly elevated white count includes like pus under pressure. So if there's an abscess anywhere, that would cause you to have a significant white count. The other thing is C. diff infections or fulminant like bacteremia. These are like the three major like no miss causes that you want to capture with a elevated white count. And depending on the what syndrome you have, you might like change your imaging. And sounds like here the platelets are low at 78,000. I was kind of surprised by that. Patients with HIV do have an HIV associated ITP. So the less controlled their HIV, the lower their platelet count. And a lot of times patients just come in and you haven't gotten the CD4 count back yet, but their platelet count is 100, and you automatically know that it's uncontrolled because it correlates directly with viral load. And the higher the viral load, the lower the platelet count. On the other hand, here we see that, okay, it's maybe her her viral load is within normal limits, but the platelet count is lower. So I would want to make sure that there's no like clumping there, and I would want to repeat that. That's the first step, is the wrong diagnosis. So just to be double check. And then after that, I want to make sure that there is no like a DIC kind of process, which is causing both like a low hemoglobin and low platelet count as well, like a systemic bacteremia, for example. And then for the creatinine, actually, I'll leave that to you, David, and then we'll reconvene about the imaging.
Yeah, I am trying to recap a little bit the case. I think what I was thinking is the initial presentation here with the flu-like symptoms, the body ache, the cough, could make you think a little bit more towards an exogenous infection, such as viral infections, and all of that, and a typical organism. But the diffuse tenderness in the abdomen and the low back pain are much more typical of endogenous pyogenic infections. And the neutrophilic leukocytosis here also points toward that direction, as you were saying. And the thrombocytopenia is there are some atypical infections that are associated with it, but is also a feature of the septic-like picture of typical or pyogenic infections. So. And for now, I just wanted to make this reflection to ask you what do you think, but I'm more inclined here to think that this is a typical bacterial or pyogenic infection, but at the same time, this is not one of the more infections that we see usually, like UDI, pneumonia, any gastroenteritis or colitis, or anything like that. Of course, any cellulitis, or all of that. And I think we are more concerned here about a deep abdominal infection. And the question here is why could this patient would get an infection like that? And I think one of the key things that we have to try to know here is if this patient has any sexual risk behaviors, because if this was the case, the management would be very different. And I think maybe the imaging that we would do would also be very different, because you could think that this is that you will go here for a CT abdomen and pelvis. That I think I would go for it. Given also given the abdominal pain and but also the alkaline phosphatase elevation and the bilirubin elevation, but I think the pelvic area is not always very well represented in the CT, and maybe this patient also deserves a gynecological exam and US by the genes. And the creatinine here being elevated could be due to many things. We want to know if there's any hydronephrosis in in a US that you could do at bedside, because if we are thinking of abscesses and that could be sitting in the retroperitoneum, for example. The possibility of compressing the ureters is there, and if this was not the case, if this is not an obstructive uropathy, as maybe, this could be just pre-renal AKI in the setting of an infection in a patient that is like maybe drinking less in the last. But the UA is it has some clues that may think that made you think that this is not the case. So here in the UA we see 1+ protein, 3+ blood, and some pyuria that is not, I think is not a lot, and some bacteriuria. I think in the setting of pyuria and bacteria, the UA is less easy to take into account, like the proteinuria and the hematuria, because this could just be like given the bacteria, this could just be due to some kind of inflammation in the urinary tract that could be that we know that could be from the urinary tract itself or from an adjacent inflammatory structure, like if there's any abscess in the abdominal region contacting with the urinary tract. This could be just the case also. So truth is, I'm not putting too much into the AKI now, because I don't think this is the center of the case, and would want to know first why is the pain, and would probably would want a CT abdomen and pelvis, and after that a US by genes. And the question of if this patient needs an MRI of the spine, I'm not sure, but with the kind of not remarkable neurological exam, yeah, I'm not so afraid in this moment, but if we don't find anything in the CT abdomen and pelvis and the US, yeah, the possibility of an infection in the spine, yeah, I think is a possibility here. What do you think, Youssef?
Yeah, I agree. I think that the other big thing I didn't mention with neutrophilia is also like an itis. Like if she has the colitis, then that would also be an explanatory. So the big three buckets were C. diff, pus under pressure, which is an abscess somewhere there, or a organ inflammation. And that's the other. Now that I thought about it, is like, could there be something like compressing the urinary tract from the outside that could cause urinary urgency without having symptoms? And similar to you, I think I would not get like spine imaging just yet. I might do like a CT abdomen pelvis with contrast. And the question is, okay, should they have low kidney function? I think in a patient who's like higher risk, I would just pursue it. And then with the CT abdomen with contrast, you would also see parts of the spine as well. And I think I would start there, CT abdomen pelvis and blood cultures, because I think if the one of these are positive, then you have at least some direction, you can take it there. But then if these two are negative, then I would do like further workup. What did you all do, Marcella?
Okay, great. So what happened is that this patient was in the emergency department, and the RPP was negative for those flu-like symptoms. The initial blood cultures after 48 hours were negative. She had a CT abdomen and pelvis, but it was without contrast because the CT was, the ER was very concerned about her kidneys. And it showed that she had a small left-sided Bartholin gland cyst. She also had cholelithiasis, but without signs of cholecystitis. She had a moderate hepatomegaly with hepatic steatosis. And that was the CT result. So she came to the floor. She was having a lot of pain. Her pain was very significant. And she was also having some right knee pain, and the leg pain was very significant for her. We tried to recollect her urine because it was contaminated, didn't reflect to cultures, and it was hard to say if she was having urinary symptoms or not. But she refused that, and we kept trying to work with her, maybe thinking about a repeat CT or doing something else, but her pain was so severe that she didn't want to do anything. She wanted to get pain medication. And we were kind of stuck there trying to understand what it was, like signal or noise. We gave her some fluids. The creatinine was trending down. And I'll stop here and see what you guys would do in that situation.
Yeah, I think like this is presented here. This is likely a severe or yeah, because that could make us think that we need more tests here. But I think in real practice, yeah, I would not be sure what could I do, because yeah, I could have done a CT abdomen with contrast, because I think there's no reason to not do that. But if a CT abdomen without contrast will see anything very very remarkable, I don't know if a CT abdomen with contrast here, maybe you could see some enhancements, for example, of the GI, the bowels or whatever. But I don't know if that would explain also the presentation. But if what I would do in real practice is, where is the pain located here? If the pain is in the spine or in the lumbar area, I think we maybe haven't done this, haven't seen it enough with the CT. And well, would talk with the radiologist to know if they see something there. But if not, I think she probably deserves an MRI of the lower back. Yeah, because you don't know what is the cause of the pain, but you don't have an explanation for that neutrophilic leukocytosis. I don't think that the Bartholin gland cyst is explaining that, and the cholelithiasis neither. So I think we have to look for a deeper infection that we are not finding. Yeah.
Yeah, and I think if we were to right now, all of us like together try to make a schema for culture negative infections, the big categories would be infections that, for example, you wouldn't be able to collect on a blood culture. So this includes like gonorrhea or chlamydia. These tests would, for example, can like see the joint, and they would almost never go on a culture. So you would do these routine tests, or like syphilis, for example, which would be diagnosed on like serologies or things like that. And this is one big category. The other big category is like zoonotic infections, like Brucella, Bartonella, Coxiella. I'm not invoking these in this scenario. I'm just saying these are like the next pathway you would think of if this were subacute. The third thing are infections that can show up on a smear. So if somebody has an infection also with exposure to tick-borne illnesses, the third like big bucket would be like look at a smear, make sure there's nothing there. And then a big fourth category, which you're alluding to, David, is could there be a collection of infection that is walled off inside an abscess? So we have an abscess, what we're checking peripherally, but there is no infection there, but the infection is just stuck inside the abscess. So this includes like meningitis, septic arthritis, and then epidural abscess, like you're alluding to. And then there's the other things that are like non-infectious, which I usually would not get there on the first 2 days, like in this scenario. I would get to that on the maybe day 4 or 5. And Marcella, did your team give antibiotics? What was the first like hashtag in your problem list so far?
So we were concerned about the potential urinary tract infection, and she got ceftriaxone. And then we're like, okay, we know that we think she has an infection here. We were thinking about pus. So let's keep the ceftriaxone, see how she does. But it was kind of that uncomfortable situation that we want to know where, you know. And then her pain was still there. Things were still like her platelets were still kind of like in the 60s. Her hemoglobin like 9.8. Her white count was still like 20 and then 17. So we were still kind of in that place trying to find out where is this potential infection, what is happening.
Yeah, and I think that's pretty reasonable. Like usually somebody has like a immune compromise and they're hospitalized. There's like this drive towards like starting like treatment, which is like reasonable. And I think things to like I would be thinking of here is that okay, can we fix the kidney function and get imaging with contrast? That's number one. And then is there anything major we're missing? So I think I would just run the checklist of like get an RPR, urine gonorrhea, chlamydia, and gonorrhea chlamydia from all sites. And then I think I don't know why, for some reason, I think of this in Noah's voice, but if somebody has abdominal pain, you have to look up and then look down. So by look up, you make sure you're not missing a PE or a pneumonia. And by look down, you make sure you're not missing anything in the pelvic tract. So I think I would be this doing similar things. And then at some point would consider like, if we don't find anything, then we would consider like spinal imaging / additional abdominal imaging. But I think that's what I would do in real life.
Yeah, so that was kind of exactly what happened. In the meantime, we're also very concerned about a possible septic arthritis because she was having so much MSK pain, and it was really hard to see if she had any fluids there or any specific inflammation on the physical exam. So we talked to ortho. We tried to tap something and see if something could be done. I was also very curious about maybe a potential like gonorrhea because she was having like this joint pain and all those other symptoms. But they didn't find very impressive. They didn't find anything to tap. They wanted some X-rays. They were more concerned about her hip. And then the X-ray just showed that she had some hip osteoarthritis. Her knee was okay. And her creatinine started getting better. And that's when we went for the CT with contrast. And also we did the chlamydia, the gonorrhea that was negative. The repeat UA was better. It didn't show anything on the cultures, but it still had some white blood cells. And the CT with contrast showed that she had signs of bilateral pyelonephritis with bilateral kidney abscesses. And they were small. We consulted IR to potentially drain, but they were not possible to drain. So we got ID on board involved. Unfortunately, all the cultures that were able to get were negative because she was already on ceftriaxone. So we just plan to treat her for a prolonged course and have repeat imaging after she's discharged. And the final diagnosis were pyelonephritis with abscesses. You guys got it.
Wow, thank you so much, Marcella. That's a really interesting case. And like we said before, like patients who are with HIV, they get like exotic intracellular infections, but they also get routine bread and butter infections, but more severe. And so thank you so much for bringing this case. I had a similar case maybe a few weeks ago, and I can't remember if the blood cultures were positive, but in that case, we also got like IR to try to like drain some of it, and we were able to get like a fluid sample from it. What reflections do you have, David?
Yeah, well, the first thing is that you can't do a CT without contrast. I think, yeah, there's almost, yeah, I think I would never do a CT abdomen without contrast in any situation. And this, if you said this is a 33-year-old female with 1 week of low back pain, urinary urgency, and neutrophilic leukocytosis, this could be very straightforward to pyelonephritis. But this case, I think, exemplifies that there are many other symptoms that can arise in non-specific presentations, at least initially, like, yeah, the body aches, the cough, the sinus congestion, the low back pain. Yeah, you could think of it as pyelonephritis, but I would think I was thinking more lower, at least in my mind, and that was maybe why I was going more toward the spine or the retroperitoneal space, more lower, I think. But yeah, is sometimes very difficult to distinguish what is noise and what is not in the presentation, and I think this is what Ravi always tell us, that defining the problem is the key thing here in diagnostic reasoning. Yeah.
Yeah.
And
And to clarify, like what David said about the contrast, usually it's CT abdomen, pelvis, you almost always need contrast. CT chest, if you're looking at the lungs, you're okay without contrast. If you're looking at the mediastinum, then you need contrast. And then for the brain, if it's just like you're ruling a big bleed, then no contrast is fine. If you're looking for like something else, then maybe contrast. So just to clarify, not like contrast in general, but for abdomen specifically, you will almost always want contrast.
I just wanted to share some reflections because I wanted to share this case of more like bread and butter, but just to mention, emphasize how important is the contrast with the CT abdomen. And it was very frustrating to us that we didn't have that in the initial, and then it was hard to explain to the patient that we needed to repeat, and she was getting frustrated and she had pain, and that with a lot of like signal from the other things and the other symptoms. So it was kind of like a bread and butter case, but it was complicated to us to get there and just to prove and feel reassurance that we were treating that infection and that she could have repeat imaging, she could follow its ID and actually see what we were treating. So thank you so much, guys. That discussion was amazing.
Thank you again, Marcella. Now back to you, Minahel.
Thank you, Marcella, for bringing this wonderful case and amazing discussion by both of you, Youssef and David. So we will first approach to the low back and compare to the leg pain. So we have to distinguish these things. And the common cause is MSK. We have to distinguish it from the red flags that can be cancer, immunosuppression, or if the patient is IV drug use, which can lead to the spinal infection. And so how we will approach, we will start with the CT if we are concerned for bone pathology or trauma, and proceed towards the MRI if we are evaluating for soft tissue or inflammatory or infectious etiology. And if the patient have a leg pain with the radicular fissures, then that will suggest nerve root involvement, and we have to consider about the deeper structure or infectious etiologies if systemic signs are present. Then about the syncope, that is usually the hypoperfusion to the brain. We have to evaluate whether it's localizing or the marker of a severity of a disease. In this case, the patient just have a general urgency and incontinence and don't have dysuria or any other infectious signs. So it raises the concern for neuropathic involvement, spinal cord pathology, or any external compression of the urinary tract. This patient have the HIV, so first we have to rule out that what's the source, whether it is IV or sexually transmitted. And when the patients go into the immunosuppression in the HIV, there will be low T cells. So that will predispose the patient to more frequent and severe infections, especially from the intracellular organism. And in these patients, full body exam is very much required, but that is like problem is that it is less sensitive in AIDS patients, so we need an imaging to confirm that examination findings. And also the low platelets here is also like due to the high viral load. Then we discuss about the culture active infections that can be like 4 categories: organisms that are not found in the blood, like chlamydia, gonorrhea, treponema. It can be zoonotic or tick-borne infection or pathogens that are present in the wall of abscess. At the last, I would like to tell that we discussed that contrast is usually required if we are taking the CT of the abdomen, pelvis. In lungs, it is not required, but if we have to take in the consideration medicinal pathology, we will consider it with contrast. And in all the etiologies other than the bleeding, we will require the contrast for the CT brain. Thank you very much.
Yeah, thank you so much, Minahal. Thank you, Marcella. Thank you, David. Thank you, Noah, again. Hope you all have a wonderful Tuesday.
Thank you, friends. See ya.